Good evening, everyone. I'm Mehdi Shishabor here from University Hospitals, Harrington HVI in Cleveland, Ohio. Excited to be here tonight with you. And we have a very intense session here, as we promised, a technical session going over the nitty-gritty, if you will, of deep venous arterialization. So with that, we're going to go quickly through the slides. This is our CME information. As you know, this is an educational event. The learning objectives are for us to learn about this new technology that has just received FDA approval. We're going to go over some of the data for a couple of minutes, and then we're going to get to the technical aspect of this, learning the pros and cons, the technical aspect of performing this procedure. And then we're going to talk about a little bit about the wound care, and then we're going to finish with a presentation about some alternative deep venous arterialization techniques. As you know, the accreditation is obviously for today, and for this particular event, it's the 1 AMA PRA category credit, and you can receive this credit with a barcode that I'm going to show you shortly. Let me introduce our panel and our team tonight. As you all know, my partner in crime and co-founder, Dr. Subhash Banerjee, is the co-moderator with me tonight from Baylor Heart and Vascular. And then we have two esteemed colleagues who need no introduction. We have Dr. Brian Lepau, who is a podiatrist. He's been very involved from early days of deep venous arterialization, and I have called him myself many times asking for advice. He has helped many of my podiatrists here in Cleveland learning the tricks of the trade, if you will, as it relates to deep venous arterialization and lymph flow and the challenges that we have to deal with lymph flow. And then we have Sid Rao, who is one of our close friends. He was at CVI last year. He did a great presentation, a lot of positive remarks we received. That's why we invited him back. He's the founder of Vascular Solutions of North Carolina. I want to be very grateful, obviously, for the opportunity for this CME event by our commercial supports from Abbott, Medtronic, and Shockwave. And obviously, we will be discussing some off-label FDA technologies here, which we will declare. As we said earlier, a lot of the presentations are obviously FDA approved. Again, you can claim your CME by going to this website and get your CME credit, and you can print it at the end. I think most people are familiar with obtaining this. I'm leaving this up for a few seconds for those that want to take a quick picture of it. Most importantly, I'm proud to say that we are very excited for next year's CVI in 2024. We are back to Denver, Colorado, by popular demand in July 18th to the 20th. And this year, we have some unique opportunities, Subhash. Do you want to talk about the aortic and the heart failure track just for a couple of seconds?
I think I won't waste too much time, but CVI 2024 are going to feature interdisciplinary presentations from our vascular surgeons that will specifically involve aortic technologies and aortic interventions, and also interventional heart failure, which will also, I think, including mechanical circulatory devices, ECMO, and other technologies and studies. So over to you, Mehdi.
Thank you. And these will be 2 additional tracks that are added. So there will be significant dedicated time for these tracks with a number of faculty specifically invited to take a deep dive into the aortic interventions and interventional heart failure. The interventional heart failure, obviously, new and exciting, and aortic, because there was a lot of demand. People have asked us to get more involved with aortic disease and intervention. So anyway, we have a number of these webinars that are on our website, www.cvinnovations.org. I highly recommend, if you're interested in coronary, structural, or endovascular interventions, to consider going to the website and checking out some of these webinars. Some have been viewed in thousands, some of these webinars that we have done, and most, if not all of them, are very technically based. So with that, I'm going to get into the meat of the presentation. As I said, I have only 2-3 slides of data. Everything else is going to be technically based for the most part. As you know, we had this important publication in New England Journal of Medicine, the IDE trial that got the promise to study and the lymph flow technology FDA approval. This is, by the way, the first device to get a below knee CLI dedicated FDA approval in the, as far as I know. The only device that we know of that we use is angioplasty. There are no other devices or medical therapy that have had FDA approval specifically for this kind of indication, for limb salvage and for below the knee. PROMISE 2 was very unique in a sense that these were patients that had no option. These were patients that we could not perform surgery because they either didn't have a target or a conduit, or they had no endovascular options. As a matter of fact, 2/3 of the patients had at least one, and majority had 2 prior interventions in trying to revascularize their foot and their limb for limb salvage. The study had a detailed wound healing adjudication by a core laboratory, and unlike any previous CLTI trials, this study included dialysis patients and Rutherford 6, all the patients that have always been excluded from CLTI trials. So we had the sickest of the sick, if you will, in this cohort of patients. And I'm going to go to the meat of the outcome. The bottom line was that we had 66% amputation-free survival in a cohort of patients that had no option. And in my opinion, they were destined for major amputation, either below the knee or above knee amputation. If you looked at by limb salvage, because amputation-free survival is mortality plus limb salvage, as you know, these patients are sick and they die. So that's a little bit more biased, in my opinion. If you want to specifically look at limb salvage, we had 76% limb salvage rate at 6 months. And we're actually working right now on the manuscript for the 1 year and beyond long-term survival that was presented at Viva, similar outcome. And we're working on a full manuscript that will be submitted in the next days. And then lastly, 87% survival at 6 months for this population. If you look at the subgroup, it doesn't really matter if you had type diabetes, if you were older or younger, if you were female or male, if you were African American, black or against whites. As a matter of fact, about 50% of the population, 40-some% of the patients were African American or Hispanic descent, which we were proud of in this trial. And in conclusion, from a data standpoint, before we get to the technical aspect of it, which we're going to present you a taped live case that I put together to share with you tonight, and hopefully get you all up to speed technically on how to perform limb flow, is that the PROMISE 2 met its primary endpoint. TADV with limb flow was safe and effective. The results were in line with the PROMISE 1, first in man, which we published a few years ago. And we really have to have a new definition for no option, because it's very sweet when a patient is told that there are no options, that they need an amputation, and you're able to offer them a new technology, a new approach, a new device that can save their limb. I can tell you the impact is, I still get goosebumps when I talk about it, and the number of patients that I've been able to save, and some of our colleagues that are on this Zoom tonight have worked on. Is very sweet. 76% limb salvage rate, as we discussed. And the interesting part of this is that we had 99% technical success rate. I am getting some text, by the way, colleagues, that people are having a hard time getting in to the Zoom. So I don't know if in the back, I know we had over 230 registrants for this event, but seems like some people are having a hard time logging in. The limb flow system is now FDA approved, and this approval was received last couple of months ago by the FDA, which is huge for our field. So with that, let me escape out of this and take you to the live tape case that we have put together. And let me share the screen here. So bear with me. This is a taped case. Is about an hour and a half of taped case going step by step over the technical aspect of DVA. I'm going to try to do it in the next 25 minutes. So bear with me as I do this. So this is the patient. The patient is a 66-year-old male who has a fifth toe gangrene, is a Rutherford class, actually 6 for the past 2 to 3 months. His status post angiogram of the left lower extremity, right lower extremity at an outside institution. It was not successful. He was sent to us for revascularization. We made an attempt here at UH. Myself, I was not successful. So after both attempts, we put the patient in the prospective study as part of the lymph flow technology. These are the comorbidities, and as you can see, he has had a prior amputation before. These are his ABI. Again, on the right side, you see that he has a toe pressure of 10 on the right and a toe pressure of 0 on the left. So obviously, there's not much flow. We are smart enough by now to know that we cannot rely on the ABI. We know that 30% of the time, the ABI is inaccurate in patients that have infrapopliteal disease. These are his foot pictures. He has a reasonable foot. It doesn't look that bad. The problem is that we know that with a toe pressure of 10, if you remove this toe, it's not going to heal. And his Wi-Fi is 2, 2, and 4 for the perfusion. So these are his diagnostic angiogram. I'm going to take a second to show you the angiograms. This is the inflow. So he has a very reasonable SFA pop. You can see the second image here that his popliteal and the proximal tibials look pretty good. And I'm just waiting for the video to go forward. And just bear with me. We're going to look at the foot here. And here's the foot. And here's what the problem is that he has really no plantar artery. There is no dorsalis pedis. There is no, and you have a quagmire, a little bit of a maybe Berger's a little bit, but mainly atherosclerotic disease with no targets in the foot. So the next step of this is the first step of DVA is pedal mapping. And this is very important because we have to find the lateral plantar vein. We like it to be around 2.5 to 3 centimeters. Sometimes it could be smaller and it's a little bit more challenging. And the process of doing this is the following. And this is probably the hardest part of the procedure because we are not used to this. The first step is that while you're in prep and recovery room, you want to bring a technician if you are not used to doing this yourself and get the training to find the lateral plantar vein. But more importantly, you need to find the track and the direction of the lateral plantar vein. And we do this, we spend a good amount of time. We put a tourniquet so that we can get that vein to plump up. And then we look through the ultrasound, panning up and down. You see it with the finger, we are showing it there. I don't know if you can see my mouse. We can also see it there. So we go up and down and we try to find the vein. Once we find the vein, we then mark it with a marker. This is very important because the plantar aspect of the foot is very sensitive. And when you go to give lidocaine, patients move. Sometimes the room is cold. The veins can constrict. So there's a lot of things that you need to be concerned and conscious of. And so if you mark it in the prep and recovery, it does make your life a little bit easier when it comes time to doing the procedure. Once we have found and identified, and you see we have point the lateral plantar vein, and it usually takes this direction. He starts somewhere here and moves medially to the medial malleolus, as I've shown here. We typically like to cover the toes with some kind of a sterile fashion, as I'm showing you. Some people like to put a sterile glove on them. This is the techniques we use upside to cover the toes so that we can manipulate without having to touch the toes or hit the toes and cause bleeding or infection. Once we have done that, we then go to the draping, and I'm going a little bit fast here. If I skipped a little bit here. The draping, the way I do it, obviously we have some surgeons right now watching. They have their own style of doing it. In the cath lab, when I do it this way. You want to lift the drape up high so you don't cut the leg, but I basically cut it open like this. And once I cut it open, I just kind of tuck it under the leg like this. The whole leg is cleaned. So for lymph flow, you need to clean everything from the toes all the way to the abdomen for the affected leg that you're going to work on, both on the top surface and below. Once we have this, we then move to placing a cuff. This is a 34-inch Stryker OR cuff, a 34-inch Stryker OR cuff that we get from the OR that they use. And we want to put this dressing on right at the level of the ankle. You don't want it to be too high because it interferes. And you will see that I'm going to pull it down a little bit as time goes on. I'm going to pull it a little bit down, and then I put the cuff on, and then we connect to the cuff. Once we have the cuff on, you see it's right at the level of the ankle. You don't want that to be too high because it would interfere with you seeing. Once we have that, we then go through the process of putting a tape. The tape is very helpful in this situation. And then we get to work in regards to getting a plantar vein access. And now life is easy because I have marked the vein. I know where it is kind of. I have put the patient in the reverse Trendelenburg, as you can see, so we can get some more flow. The cuff is now inflated. You can see that I see the vein going up and down. You want to get your access as distal as you can. You don't want to be too proximal. Now, sometimes we have to because the vein is not as big, more distally in the foot. But the goal would be to try to get as distal of access as you can. You want to stabilize your left arm that is holding, if you're right hand dominant like me, so that the hand is not moving, is very stable. And we are now going to give some lidocaine. Now, before you give lidocaine, you want to warn the patient and you want to make sure the patient is sedated because this is very sensitive, as we all know, the plantar aspect of the foot. And we want to make sure that the patient don't pull their leg. This happens frequently, and I've learned in a hard way. So once you give the lidocaine and you want to be generous with this, your hand cannot move. That left hand has to be solid. You don't want to rotate it. You're using the landmark. You give the lidocaine. Now we come in with a needle and we want to get access. Sometimes you go in a little bit wrong direction, but it's okay. You can pull back and then you can get access. In this situation, we were lucky. We were able to hit it on the first approach. So now we have access in the plantar, lateral plantar vein. The cuff still is up. We now pass, and I'm using here an 014 command wire. All the wires you use for the lymph flow technique should be 014 because the technology is 014 technology, and you don't want to have to exchange wires if it's not necessary. In this situation, I like to have the eye very close because sometimes the wire is not going. You want to be able to fluoro quickly to see what's going on. Now I have gently advanced the wire. The wire has looped. I'm not going to push it anymore so I don't dissect or tear or do some damage. I'm going to leave the wire like this. I was pretty confident I'm in the right place. Now I'm going to put the micro catheter in there, micro sheet, one of those Cook pedal access sheets, and see where I am and see if I can advance the wire up the vein. And here I am bringing the sheet. So once I have the sheet, and I just skipped a little bit, I have the sheet in there right now. Now I can just pull the wire back, get rid of the loop, advance the wire, and the wire typically goes up very easily through the posterior tibial vein and goes up the posterior tibial vein up towards the knee. Now we have access in the plantar vein. We have a wire going up, and we are in a good situation. Now we're going to bring our attention after we have done this. And typically, I move at this point, right at the moment I get the plantar vein access, I give about 2,000 of heparin. You don't want the arch or the plantar veins to thrombose. So give 2,000 to 3,000 of heparin. And then the next step is to get your access, antegrade access in the common femoral artery to come down the artery. You don't want to give a full dose heparin and then have a complication of going. That's basically the point. So now we're going to move to the groin part of this. And now that I have access here, before actually going there, I usually take a venogram. We have the cuff up. We're going to take a nice venogram. And the point of the venogram is to see where we are crossing here at the level of the ankle. We want to make sure that the wire is in the right place. Usually there are two posterior tibial veins. We also want to watch the arch here. And you're going to see here that I've shown, we want to see this. We want to see that the arch is present. Here you don't see it very well in this still image. But believe me, there was a little light arch that I could see, and that gave me the confidence that I can get through the arch at some point. Now that we are done with this, now we go to the groin, and I'm going to skip this part quickly because I think most of you know how to do this. This is basically antegrade access. This is a 7 French technology, and now we have antegrade access, and we're going to come down with the sheet, and I was having some challenges, but these are normal challenges. Now at this point, I have put the sheet. You see the sheet right there at the pop level. I have the retrograde wire coming through the plantar vein. You see my PT right here. I want to make sure that this wire is close to the posterior tibial vein, and we have a good marriage, good parallel, close connection, so that we can make our connection together. Once I make sure that's the case, and here we are talking about that, we are making sure the wire actually in this case, because of tributaries, had gone from the posterior tibial vein proper to the other posterior tibial vein. So we actually pulled the wire back and repositioned it. But you can see that this wire that is coiled here is in the artery, the other wire is in the vein, and we are close enough. And we try to get the DVA as distal, the lymph flow as distal as we can, so that we can preserve the proximal collaterals so we don't get proximal steal. So if we can, and when Sid shows his case, he will show you that, you know, he's doing these cases very distal near the ankle. And unfortunately, in a lot of our patients, they don't have that kind of anatomy. There is diffuse disease, and we cannot get that far. In this particular case, we had a little bit of a room, so our plan was to get the reentry somewhere here. Now, once we have done this, now we go to the where we're going to do the what we call the connection. We're going to connect the vein and the artery together. And here we use 2 devices. One is called the V-Siever. This is the basket, I call it, that receives the wire and the needle from the artery. This device sits in the vein. And then we have the ARC device, which is the needle that's going to be delivered from the artery into the vein and into the V-Siever to capture the wire and externalize the wire and create the connection. So that's the V-Siever. And now this is the ARC device, and that's the needle, and you basically flush it in a standard format. Now you have the 2 devices. Now we're going to go in the system. So now we go in here, and I'm going a little bit fast for the sake of time. Let me get us in the right place. So yeah, so now we want to align the 2. So we have previously marked by the ruler. We know where the PT starts, where is the beginning of the PT. We know where we want to enter. Here we have decided to enter somewhere around 8 or 9 right here. So we want to put the V-Siever somewhere in here in the middle of where the needle is going to enter. So we want the needle from the arc to enter in the middle of that cage, that V-Siever device. And that's what I'm going to show you here in a little bit. So here we are. Now we're going to release the V-Siever. So that's what we're doing. So now the V-Siever is deployed. You see the cage right there. You see my needle right now is here. That needle is too distal. I'm going to miss the cage. So now I'm going to reposition it. I'm going to pull the needle back a little bit, pull the V-Siever down, and try to bring the needle, right here is the needle, to the middle of the technology. And here is where I'm doing that. You see that? That's where I'm doing that. Once we are in a correct position from the standpoint of where we want to enter the V-Siever with the arc, we then have to align the 2 devices. And the way we align is that there's a marker right there, what I've shown you with an arrow. We want to look at that marker carefully and understand where the needle is coming off. So the first step is what we call the eclipse technique. The eclipse technique. And the eclipse technique is where we manipulate the II to make sure that the V-Siever and that marker are right on top of each other. You want them right on top of each other. And that's exactly what I'm doing here. I'm rotating the II, getting that V-Siever and the arc right on top of each other so that they're right aligned. Once I have that alignment on top of each other, the next step is to understand which direction is the needle is going to come out. We want the needle to come, if you will, if I'm looking at the screen, to the left. So we want to make sure that the needle is going to point to the left. So I'm going to show you now how we're going to assess that and how we're going to determine how the needle is going to come out. So the first thing we do is that we go in a 25-degree angulation now. Once we have them all aligned, we're going 25-degree in the other view. And what we see here is that the thickness of the needle direction. If you see the white portion, it means that the needle is coming anterior or posterior. If you see the thin area, it tells you that the needle is coming to the side, to the left or to the right. So thick, anterior, posterior. Thin means to the left or to the right. Now, is it coming to the right or to the left? The way we tell is where the wire is. You see this thin wire right there? The wire is on the left, so it tells me that the needle is coming on the right. So now I know that my needle is coming to the right. I have the thin bar, which tells me it's going to come on the sides, not anterior and posterior. Now I'm going to advance the needle, and here we are. We're going to push the wire in there. And usually for this entry from the artery to the vein, we like to use the nitrix wire. This is a silicone-coated wire, and I like it a little bit better than the run-through. Those are the main two wires we like to use, either the nitrix or the run-through wire, doing the eclipse technique with the V-Seaver and the arc device. Now, once I've done that, I'm now going to advance the needle. And for the sake of time, I'm going to skip a little bit of this. You see the needle is out. The wire is now out. Once the wire is out, we gently pull the needle back into the arc device. And before we pull the needle, we just manipulate a little bit up and down to make sure that we are in the right place. So once we move the V-Seaver, because the needle is inside of it, if the needle is moving, you know that, okay, I am in the middle of the V-Seaver device. Now I know I'm in the right place. I pull the needle back. Now we're going to capture the wire. So the way we capture the wire is that we advance the V-Seaver sheath and gel the wire into the sheath. Basically, now we are holding the wire in our V-Seaver technology. Now from the top, from the groin, we're going to advance the wire, and from the foot, we're going to pull the V-Seaver out, basically body flossing the nitrix wire or the run-through, and now we have a connection from the artery through the reentry into the vein out of the foot. This is the most kind of the most challenging part of the procedure. Once you have this done, then we do a little angioplasty with a 3-5 balloon of the reentry section. So let me get to that. This is the balloon that we brought, and we know the reentry is somewhere around 7 centimeters. We're now going to inflate this balloon. And the reason we do this is because the next step is to do valvotomy of the valves in the vein. And to be able to get the valvotomy down, you need to have a little bit of an angioplasty to be able to get to do the valvotomy. And this is the angioplasty portion of it with a 3-5 balloon. You can use shorter balloons. I like longer balloons because I'm going to angioplasty the vein anyway. So I just put the longer length in the vein. And here you see right there, right at 6, you see that dent. Can you guys see it, Subhash? That dent right there, you know that that's the reentry point of this. Once we have done that, now we're going to go to the valvotomy. And here's the valvulotome. Now, this is a priority valvulotome. It's the only valvulotome that cuts in the forward direction. And that's the beauty of this valvulotome, because it allows us to macerate the valves in the posterior tibial vein in a forward fashion using the lymph flow technology. And here we come with the valvulotome. And the way the technique for this is that you advance the journey, you open it. First of all, you want to make sure you're past the reentry. You don't want to cut the reentry. So you want to make sure you're past that 6 centimeter mark, maybe even a couple centimeters down. So you want to make sure you're in the vein. Once you're in the vein, you open the valvulotome, you advance gently, you're going to catch the valve. When you catch the valve, you want to rotate a little bit, go back and forth, and just macerate that valve. And then you advance forward to the next valve. And you do the same thing over and over again until you have macerated the valve and you're able to go all the way down. Now, usually the tough valves are right here at the ankle. This is where we have a number of valves and some fibrotic bands, and there's a sheet there. And this is, we have some challenges here. And this is the area you want to spend some time and do a good job. And you want to push the valvulotome all the way down to past the calcaneus. And I'm going to show you here, sometimes we have to pull the sheet back. Remember, we have a sheet in here. So I'm going to pull the sheet back here a little bit. And I'm not going to take it all the way out. I'm going to take it back as much as I can. And then I'm going to advance the valvulotome all the way as far as I can go to about here, a couple centimeters past the calcaneus, creating and destroying those valves so we can so we can inflate and be able to, and you see the valvulotome coming in right here, right to the distal portion. Once we have done that with the valvulotome, we then go with the 5-0 balloon and do angioplasty or venoplasty to make sure that the veins truly, those valves can open. And sometimes you need to spend some time here, a couple of minutes, 2, 3, 4 minutes, to make sure that you get those open. And as I told you, most of the challenges are at the level of the ankle right here. We always have some challenges here, but with some patients, you can get these open. I would not proceed to the next phase until you get these open. So if you have to go back with the valvulotome and do a little bit more, please do it. Don't deploy the stent and have a 50% residual and you're not able to crack those valves. Those valves can sometimes be very challenging. But with some patients and work, you can do that. Once we've done that, you can see I'm spending some time here to do this. And believe me, after a little bit of time, this works and it comes out very nicely and you can get it wide open all the way. Now, when you do this, be very careful that you don't dilate the connection with a 5-0 balloon. So you want to be very careful that while you're doing your venoplasty, you don't pull the balloon back too much and you do valvuloplasty of the connection between the artery and the vein. Remember, we did that one with a 3.5 millimeter balloon, not with the 5 balloon. The 5 balloon is only for the posterior tibial vein all the way to the level of the calcaneus, to the level of the foot. We then go with the stent. These are covered stents. Again, these are lymph flow stents. And we take the stents in. I'm not going to waste too much time, but you want to position the stents not past the calcaneus because we don't want it to get crushed. So typically, the farthest we go is about 1 centimeter before the calcaneus ends. So again, I'm showing here that I'm looking at my pictures that I took earlier. I want to see some of these branches because I want to cover as many branches as I can so I don't get distal steel. And that's the whole point of looking at your images that you took earlier, so you can cover as much as you can. What you don't want to do is to pass the calcaneus, and we don't want to do that. So here I am deploying the stent, and the beauty of this is that I can deploy it distally a little bit and then pull it back to the position that I want. And this is what I'm showing. I'm showing that I am deploying it distally. I'm going to start releasing it. I don't want it to be this far. I want it to be about 1.5 centimeters before the end of the calcaneus. So I'm not going to have someone hold the sheet for me, not at the level of the skin, but at the hub of the sheet. Because if you hold the sheet itself, the stent may not deploy. So you want to hold the hub of the sheet, not the actual sheet. And now I am going to release the stent. After it's released, I pull it back 1.5 centimeters, and I'm going to land it somewhere around here. For the sake of time, I'm just going to, I think you guys know what I'm talking about. I'm going to skip this. Now we place a couple of stents. Now we're going to get to the proximal part. And for the proximal part, we use a pro-priority stent by lymph flow, which is a tapered stent. These are the stents that are 3.5 by 5 stents. So the 3.5 is in the artery, 5 is in the vein. And having a tapered stent really makes a huge difference for us to be able to get that. There's a size mismatch, obviously. So we need to have that there. And I'm just showing the stents here. This part is not that exciting, so we can skip it. And this is now I've deployed that pro-priority tapered stent. It's the 3.5, it's the 5. We now have a connection. Now we go to the third and the last hurdle of the procedure, which is could be one of the challenging part of the procedure, which is now we have to come down and cross the arch. And after posting the stents, so after the stents are deployed, we post the stents with a 5-0 balloon again. We post the anastomosis with a 4-0 balloon, 3 by 5 by 4-0. And now we come down to cross the arch. And I'm going to show you here quickly in the last 5 minutes. So here I am. And this, you have to be patient. This can take a little bit of time. In this case, actually, we had some challenges. I'm going to skip some of the challenges. But you can see that finally, I was able to get through the arch. and here I am, my wire passed, and then once I'm through the arch, I now come down with a 3/0 balloon, and with a 3 mm balloon, we are able to angioplasty the arch, and here is the balloon. It's going to come down now, and here we are. We do an angioplasty here first a little bit, and then we push it a little bit farther down to about here. You want to be very gentle. The last thing you want to do is that do all this work and then rupture the arch. And if you do that, you might as well say goodbye to that leg. So you don't want to rupture the arch. And this is actually how it looks. For those of us that do the pedal arch work, arterial work, we are familiar with this 8th figure that we see. And this is on the venous side. This is how it looks. I just wanted to show you guys how that looks. And here we go again. I went a little bit farther down, and I'm doing a little bit more, very gentle, sometimes to 2, 3. You can see the pressure here. I'm only at 3 or 4 atmospheres. You don't need to go crazy. As long as it dilates and the valves are dilated, you are fine. And here is the picture now. Here is the lymph flow. We had some issues here. We went back with the valvulotome, did a little bit more valvulotomy here and angioplasty, and we were able to get a final picture. Here is, I'm doing a little bit more valvulotomy here because of the lesion, and that was there. And here's the final picture. And this patient is actually doing fantastic, and we are continuing to follow him. We just did this case for this to be able to show you guys. So the wound has not healed. Happy to load it on the CVI webinar website for you guys to see it in the next couple of months as we heal this. So I'm going to stop this. Subhash, I don't think I talk fast to begin with, but I don't think I've ever talked this fast in my life.
This was amazing. Mehdi, I'm sure there are a lot of questions coming to the chat. Before we go on to Dr. Lapao, let me ask you, do you guys do any kind of venous mapping procedure? Are there any other techniques, or you just base it on the angiogram you obtain in the lab?
No. Remember, we said in the beginning of the presentation that we need to do extensive ultrasound-based vein mapping of the foot. You want to know where is the lateral plantar vein. You want to mark the lateral plantar vein. You want to know the direction of the lateral plantar vein. And, you know, we don't do routine venous studies to see if there is DVT or those kind of things, if that's the question.
What I meant.
Yeah, I don't normally do it routinely. It was not part of Promise 1 or Promise 2. If the patient has history, we examine the leg. If there is extensive varicosities and those kind of things, we may do something. We may take consideration. But honestly, that has not been a major issue for me. As a matter of fact, I have never had a patient be excluded for that reason.
Sounds like a plan.
I think if you agree, Subhash, for the sake of time,
we'll
keep the questions to the end, if you allow me. Let's get to Dr. Lapao, and then we take some questions before we go to Sid. I think this presentation is very much tied to what I just showed you technically, because you can do all this technical stuff. And if you don't do the proper wound care, which is very different for lymph flow than other technologies, you can mess up the whole leg. And I myself have lost at least 3-4 legs because of miscommunication with podiatry and how these wounds should be treated. Brian, thank you so much for accepting this. And I know tonight is the first night of the holidays and you are here. So thank you so much. Thank you for doing this.
Yeah, thanks so much, Mehdi, and the entire Cardiovascular Innovations Foundation team. We'll get right in. And Mehdi, you kind of hit the nail on the head. Without proper wound care, the limb will, your risk of losing that limb is quite high, and all the work that's spent trying to revascularize that leg kind of goes to waste. So, we'll talk about some tips and tricks, and if we have some time, get into a couple cases here. So jump right. These are my disclosures. And so these are kind of the typical actions, what happens, and the things that I look for after arterialization. Things that we can expect: pain and swelling. If it's mild to moderate, we discharge the patient post-operatively and we follow them in the outpatient wound care center. When we get over to the more moderate to severe categories, we have to kind of further investigate those patients to figure out, is the pain secondary to infection? Is it secondary to the revascularization? So there's more investigative things that need to happen before we discharge that patient home, because then they'll just rebound back into the hospital. Is it because of high flow volumes, low flow volumes? So the things we have to kind of sort out is how do we get to that point to be able to discharge those patients in a pain-free manner or on minimal pain analgesics to be able to kind of help get them to the hump and manage that wound in a particular manner. Certain things we can talk about as well is something called the decompression forefoot or decompressing guillotine TMA, and that's opening of the forefoot to release some of the pressure, and we'll talk about that further on in the lecture. Some of the best practices for the wound care include indications for early foot surgery really only include infection and pain, and we'll talk about this is not your typical revascularized type patient. These patients are very different, and so they have to be managed different, and a lot of times we have to sit and wait before the arterialization circuit matures before we can go and do any foot surgery. We want to delay any minor amputations until those clinical evidence of tissue oxygenation or perfusion. That's typically at about a 4 to 6 week mark. And we say, wow, that's a long time to wait. But this is kind of what we found. And we're using different tools in our toolbox to help maybe shorten that window. But typically what we found is about 4 to 6 week mark is when we can move forward with reconstructive surgery on the foot. So some strategies for wound care in this patient population, we want to do the following. We want to monitor these patients closely for pain, infection, worsening of the wound site, and tissue discoloration. And how do we do that? We can do that via investigating just clinical evaluations. I typically see these patients on a weekly basis. They're given our contact information in the clinic. So there's a very tight-knit, close follow-up of these patients. We just don't let them go and have them come back in 3 weeks for a follow-up. We want to investigate these various options and these issues with ultrasound, angiography. And for me, radiology, plain film x-rays is enough to kind of rule out any type of infection markers that we're looking for, that in addition to a physical examination. And I couldn't say it more that multidisciplinary care and communication are really essential for the successful outcomes of these patients. Without that dedicated team, your chances of limb loss are going to be quite high. I am constantly communicating with my vascular counterpart to ensure that we're on the same page when it comes to managing these patients. Are they optimized and they are at the point where they need forefoot reconstruction, or do we need to wait further? So communication is intense and very important, not just amongst the teams, but also the patient and the family. Everybody's got to have buy-in. Everybody has to be on board for what's happening with this foot. Some of the things to expect post-op: pain. Pain seems to be the most common thing that happens, and we have to figure out, well, what's that pain from? Is it post-procedural pain? Is it from swelling of the extremity, or is it ischemia that's created from the conduit and the circuit that happens with the arterialization? The practitioner's choice for pain should include regional anesthetic blocks. We've started to do those more commonly in some of these more high-risk patients, and we found that helps to carry them over the hump a little bit. We'll talk to our anesthesia team about placing a block. IV and PO, systemic medications. And severe pain that has not resolved in 24 hours, 48 hours should raise concern for new ischemia arterial steal and should be further investigated with the tools that we discussed. Swelling is also a very common thing that happens in the patients. It's common for about 3 to 4 weeks post-op. Sometimes that drags on further on. It's secondary to a sign of blood flow to the foot in the treated limb. So you get an immense amount of blood flow flowing down to the foot. So the edema is going to become secondary to that. Untreated edema may inhibit the wound healing. So it's very important to use techniques to manage that. We don't want to do layered compression dressings. Sometimes just elevation and a light compression, such as an ACE wrap, will help kind of reduce some of the discomfort in the limb and help reduce subsequently the pain in that person's extremity. Changes in wound status. These are the things we're most commonly looking for. Acceleration in wound healing typically happens in about 4 to 6 weeks. Prior to that, you're going to see sort of breakdown of that wound site, and you can expect things to get worse before they're going to get better. And typically that 4 to 6 week mark, as I mentioned before, is secondary to maturation of the arterialization site. Tell your patients the wounds are likely going to deteriorate prior to this time. Go ahead and prep them. This is something we commonly see. And so we want to make sure the expectations are set early for these patients. And so that way, when things do happen, there's less concern on what the process is occurring there. And then we want to use caution performing any surgical debridement within that first 4 weeks in this particular patient population, especially in the presence of venous hypertension. Again, there's only 2 drivers for early foot surgery, and that should be infection and pain. Clearly, if the foot's infected, you want to temporize it with just minimal surgical technique to remove the necrotic or infected tissue. It's really the only thing you want to do, and then you leave it set. Again, remind the patient and the family things are going to look a lot worse before they get better. But you always should go into that plan, thinking about how you're going to reconstruct that forefoot. So you have to have a calculated way of removing that infected tissue and not being overly aggressive, so you don't get into the arterialization bypass site, and B, remove enough tissue that you don't have a reconstructible foot that's going to be functional. It's all about trying to create a functional outcome for these patients. And then pain. If the patients have severe pain and ruled out all the vascular side of things, sometimes doing a open forefoot amputation to relieve some of that pressure, we found it makes a huge difference in that population, and pain will typically drop significantly in the first 24 to 48 hours after doing that. And again, any significant deterioration in the wound status should warrant a second opinion in consideration for arterial steel. So how do we, this is kind of a typical patient that we see in our clinics. We see patients that have been elsewhere, have undergone reconstructive procedures of the foot, and have failed. They come to us seeking a second opinion because they've already been told they're going to lose a leg. And so this is kind of the world that we live in. And so how do we manage these types of patients, and what are the things we should look for, and what do we do? How do we take a foot like that looks like this here from a failed transmetatarsal amputation and to the picture on the right here, where it's a fully healed in a type foot? So we'll jump into a couple of cases here. Some examples of best wound care practices. You see here, you have a gangrenous necrotic foot secondary to ischemia. What we've found is works best for these patients is not to create a flap. We found that creating a flap causes a lot of necrosis at the flap site. The wound winds up dying back and has unsuccessful healing. So we've moved forward and popularized and performed more of what we call the guillotine transmetatarsal amputation, which is just an open transmetatarsal amputation. We generally do the open transmetatarsal amputation, and this is, again, after that 4 to 6 week mark. Prior to that, the only reason why we do foot surgery again, is for infection or for pain management. And those you kind of leave in set. You don't do much with them after the initial surgery. You push them out 4 to 6 weeks, and then you can go back and reconstruct that foot. But once we get to that point, we'll do the open guillotine transmet. If it's a clean and healthy wound bed, you can cover it primarily in the OR with a skin substitute of your choice to bridge from the tendon and bone coverage to a healthy granular base. And then ultimately, we're trying to get those patients to split thickness skin graft. And the whole time frame of this really should be about 4 to 6 weeks from the time that the amputation is done to the time that they have that skin graft placed. Again, it's all about creating a nice functional outcome for these patients. We don't want to have a mangled foot because if they can't ambulate on that foot, sort of defeats the purpose and why we're doing the reconstruction in the first place. We advocate use of split thickness skin grafting. We typically use that in conjunction with negative pressure. Negative pressure is always used at a lower pressure setting to help to avoid collapsing. Number one, not just collapsing at distal vasculature, but also creating pressure necrosis around the distal end of the wound site. And then here you see that kind of healed wound on the right-hand side. And it's really important to note, just a quick thing on the negative pressure side of things, you have to be really careful about placing that track tube here. You can see my little marker here. These tubes are not benign. This suction tube here it's very hard, doesn't have a lot of give to it. And so what I typically do with these patients is I pad them all the way up the leg, because I've seen necrosis happen just from inappropriate application of the wound vac. So you have to be very mindful of that. Here you can see another clinical case. TADV was performed. Minor amputation was initially performed. This is in one of those cases where there was concern for infection. However, in this particular case, we closed the wound. This is one of our early cases. And as we've come to learn, closure of these wounds is a no-no. They don't heal, they don't do well, and you have to get very comfortable with leaving these wounds open. Too tight of sutures can cause wound ischemia at the edges, and then the primary closure can also cause infection. And so what we've done is we wind up leaving these open. And as you see here, the amputation was done and it quickly died back. We wound up going and revising that into what we called the guillotine transmetatarsal amputation. And lastly, the patient went on to heal successfully here in about 6 weeks post a guillotine transmetatarsal amputation. In the last clinical case here, again, just kind of demonstrating here, those guillotine transmets really are quite an impressive procedure to perform. We start with sort of a debridement and removal of the necrotic tissue, followed by negative pressure at a low pressure setting. And the end game is application of a split thickness skin graft and then ultimate healing and diabetic foot remission in this particular population. In the last case here, just kind of walking through, showing again the same step-by-step process. There is some clinical evidence that we've found doing these guillotine transmets. There's not a lot written in the literature about doing these open transmetatarsal amputations. And so when there's not a lot written about the procedures, there's a lot of anxiety about doing these procedures. It's certainly outside of the comfort zone for specifically the podiatry population to do procedures, A, open, B, without tourniquets, and C, having them open for extended periods of time. And so it's something that we all have to get comfortable with. This is a new procedure. This is something that's outside the box thinking. And in order to get these patients into healing, you have to kind of think outside the box and be willing to push the envelope towards getting these patients healed. And one quick word about this population as well. It's really important that not only do we do proper foot scaping or revisional surgery of the foot, reconstruction of the foot, but you also have to think long-term. How are these patients going to ambulate? Again, it's about creating that functional outcome so these patients can ambulate. They're coming to us because they've been told they're going to lose the leg. And if we don't do a good job at managing the soft tissue of the foot in a manner to the way they can have a functional outcome, and they don't use the leg, it's sort of counterintuitive to what we're doing. So I always work closely with our orthotic and prosthetic department to design devices that are not overly cumbersome. This may be a larger device, but the newer generation devices, if necessary, are much more low profile, and they can help assist with ambulation if necessary. A lot of times these patients go on just to wearing a regular extra depth shoe with a little insert to help remove any pressure points. And we have a fair amount of our patients do quite well. And again, this is all in a relatively short amount of time. From the time the arterialization to the time that we have them walking again is a very short period of time. In fact, what we found with these guillotine transmetatarsal amputations is that we generally are walking these patients typically 24 to 48 hours post-op, which is quite remarkable. In the typical the typical amputation patient, when we do a transmetatarsal amputation, generally those patients are not weight bearing for 4 to 6 weeks. And in this particular population, they're already very sick. If you tell them they're not going to walk for 4 to 6 weeks, sometimes they may not walk again. And so what we found that there's not a flap to protect. Negative pressure is usually applied immediately post-op. So there's really no reason why these patients can't ambulate. And we have a study that y'all can find online that discusses that. We looked at a retrospective study of about 60 of these patients, and they all have very successful outcomes. So just kind of wrap things up, I know it was a very quick run through on the procedure and the technique, but I think that it's important to understand that these are not our typical traditional revascularized type patients. They have to be looked at in a different manner, and they have to be treated very different. Again, avoid aggressive debridement amputations in the pre-arterialized patient. Again, 2 drivers: infection and pain. Early debridement, less than 4 to 6 weeks, must be performed carefully. You only want to focus on removing necrotic infected tissue. Leaving necrotic toes there are fine, as long as you're monitoring them and ensuring they're not converting over to wet gangrene or infection. Avoid tourniquet use. Again, very difficult for podiatry, but what we don't want to do is cause vascular occlusion. And these patients happen to bleed a lot. And I want to see what's bleeding so I can actually ligate the vessels during the time of the procedure, or ligate whatever is necessary to help minimize that bleeding risk post-operatively. Inevitably, it's going to happen. So you want to find that your coagulant products of choice in order to ensure that you're not getting called on a routine basis post-operatively for these patients bleeding. You want to avoid too proximal foot amputation. It should be more mid-metatarsal. Once you start getting more proximal, you may damage the lateral plantar vein, which again can disrupt the outflow for that foot. In some cases, when the arterializations have matured, you can go a bit more proximal if you're looking to perform a show parts amputation. But I think that's few and far between, and those are really reserved for patients who kind of have sort of a really a different type of scenario. And then again, I can't say it enough, avoid primary closure of these wounds. We've seen it over and over again with the PROMISE 2 and now with the PROMISE 3 study. Closure of these wounds ultimately are going to fail. Don't close them. Get comfortable with leaving them open. I know it's out of the traditional handbook from what we're used to be doing, but they work, and they work well. So don't close them, leave them open, and they'll heal by secondary intention, or there's a lot of great products out there that can help assist to get those patients healed. And if you're going to use negative pressure, it's very important that you keep it at a very low pressure setting. We've all learned by experience. And so these are the kind of the experiences that we discuss here in this setting. And again, prepare for bleeding. These patients bleed a ton, more so than any other patients. We're not using tourniquets. And so use your coagulant products of choice, have them on hand. And that only just saves you time in the OR as you're trying to work through and do reconstruction of the foot, but also post-operatively that you don't want to get called in the PACU. And then when the patient gets to the floor and it's just a bloody mess. Again, I've been there, so I know. So I've sought out products that work best to help with coagulation intraoperatively and also postoperatively to ensure that I'm not getting called consistently. And again, all suffice to say, you must have intense communication with the team, not only with the team, but with the family. The family has to be on board for what's happening. The arterialization component from the vascular side is just a small portion. Once you get to the wound side of things, it can tend to linger on, longer than 3 to 4 months. And so you want to make sure that the family has buy-in, the patient has buy-in, they understand that these are salvaged limb. They've already been told they're going to lose the leg, and we want to be successful at getting them not only just a keeping the limb, but also having a functional outcome so they can get back to living their lives and being productive members of our community. And with that, I thank you very much. I know I breezed through things very quickly for sake of time. If anybody has questions or would like more information, feel free to reach out. Again, thank you so much to the team.
Brian, that was fantastic. Brian, that was fantastic. Hope you have a glass of water to take care of yourself. We are beating our panel here tonight.
That's right.
But I think that, believe me, the information that you're getting from Brian is gold. I'm not kidding you. And anybody that has done limb flow and has done this kind of work will tell you that we have all lost a few legs in a hard way, learning, and we didn't know a lot of this. When we started first in PROMISE 1 and our earlier experience, we didn't know, and not using tourniquet, not putting sutures, not doing primary closure, not not putting tight dressing, as Brian said, not stopping anticoagulation. All of those things are not things that our colleagues are comfortable with. And this field still is in infancy. So you have to communicate, you have to talk, and you have to communicate. So I wanted to, let's do this presentation by our colleague, Dr. Rao. And then we open up, we always go over by a few minutes. So for those that want to stay, great. And we're going to have some Q&A. I'm going to answer some of the questions. There's some good questions in the chat. We'll answer after Sid. Sid has been doing some nice work, and he presented his work at CVI in 2023 in July in Austin. And we felt that, it would be good to see some of the work that he's doing. And there was a lot of requests, actually, to have him present the work that he's doing in the ASC. And Sid, take it from here. Thank you. You're on mute, by the way. You're on mute.
Yeah, sorry about that. So thank you, Subhash. Thank you, Mehdi. Thank you for the opportunity. CVI 2023 was fun. I'm happy to do this here again. My job is now to help you kind of learn to drive a 1999 Honda stick shift after Mehdi's told you how to drive a 2024 BMW X5M. So I'm an OBL operator. I don't go to the hospital. So I started doing DVAs about 8 to 9 years ago almost. And so I've gone through multiple iterations of attempts. And we have kind of fine-tuned our technique. So this was the technique that I presented. So we'll breeze through these sort of redundant slides. So these are the kind of patients I get to see in my practice. These are all my patients, terrible Rutherford 5 and 6 patients. So this procedure also works actually for gangrenous heels when the posterior tibial artery or dominant peroneal that supplies the heel is occluded. So the advantages of the technique that I'm going to show you is that it uses off-the-shelf devices. So when you don't have access to sort of the more recent devices, you can try to still do this on your own in the OBL. Like Mehdi said, I try to make my anastomosis or my AV crossover a little bit more distal, primarily because there is a decent data now that it reduces the amount of hyperperfusion injury also. It also makes your foot and ankle surgeon's life a little easier. Like I said, we've sort of fine-tuned our technique now to do it in skin to skin in under 2 hours in an OBL, and the patient actually goes home the same day. So the principle is the same, A to V connection. Instead of it being really high, we do it a little bit more distally. So like Mehdi said, we get our lateral plantar vein access. We actually have a pre-DVA worksheet that our RVT kind of finishes, and I review those scans at the time of the review the images at the time of the scan to know that the patient's a good sort of candidate for percutaneous DVA. Like maybe we make sure we tie a tourniquet in the holding area when the patient comes in. So this vein is plumped up nicely. Ultrasound guided access. I usually start with the Merit Medical 6 French Prelude Ideal sheath. This is 7-centimeter sheath. And I'll tell you why I start with a big sheath. So as soon as we get into the sheath, into the vein, we take a picture. And then after that, we get antegrade groin access. I typically access the SFA, proximal SFA in a compressible segment, or the common femoral, but usually a proximal SFA because I don't go bigger than 6 French. So this is one of the patients that I showed you. So there you can see there's hardly any flow. There's a little anterior tibial flow, and the dorsalis pedis kind of peters out into nothing. There really is no common plantar flow below the ankle. There's a trace or trickle sort of posterior tibial flow. It's a heavily calcified vessel. Sorry, there's a little movement artifact. So there are several sticking points in performing a DVA. I was one of the first guys in the state to perform this, and when I started doing them, we would take an outback catheter from the artery and then blow up a balloon in the vein and then puncture it. And so I've gone through all those techniques. The VAST technique is an elegant technique to perform a snare from above, snare from below, and then a percutaneous needle under X-ray guidance. The only problem is I've seen that it works great when you can get the artery and vein to lie on top of each other. Sometimes you can externally rotate the hip, flex the knee to try to get the vein and artery to lie on top of each other, but sometimes you just cannot. It doesn't matter what your camera's eye angle is or what your patient's foot position is, they just can't do this. So what happens when you have a situation like this, when the artery and vein are beside each other? And this was the main problem I had in the OBL. So we said, why cross over from artery to vein? So we actually now, this is the reason we put a 6 French sheath in the vein. We take a Pioneer catheter from the vein. And then, as you can see, it's not a terribly distal DVA, but it's about, mid-leg DVA. So we make a connection from the vein to the artery. Sometimes if the artery is very calcified, there's sort of a first procedure that we perform where we actually take a Diamondback or a shockwave, if it's in the hospital. If you guys are in the hospital, you can open up the PT nicely so that the puncture site becomes soft and malleable, so to speak. So once you've done that, then the rest of the procedure is just following a sequence of steps. Earlier, we used to put a snare in the popliteal artery and reverse this wire, the 14 wire that we would advance to the Pioneer catheter. But you realize the PT is diseased and concentrically calcified enough that if you take a 5 French Bernstein catheter and shove it into the proximal part of the PTA, your 14 wire will actually enter that. So there's your cheap snare. Now, this is where our procedure gets a little interesting. What I've consistently found is that the AV crossover site is often difficult to track with anything. Now that even if you have the wire flossed, it's very difficult to track with anything consistently that is 035 or higher. So straight away, we take a 1.7 Spectranetics or a 1.5 Orion laser. And at a low setting, we actually laser the A to V crossover site. And once we've done that, we also actually take it down to where the valves are, up to the level of the mid-calcaneum, as Dr. Shishabur was saying, and we laser those sites. So now that we've done that, this is basically our percutaneous valvulotome that he was talking to. And after this, it's what he was referring to. So you take the PT wire, reverse access, wire the pedal venous arch, and get into the anterior tibial vein. After this, it's balloon venoplasty. You take the 6 French sheath out of the lateral plantar vein that you've accessed and do internal external tamponade. After that, what we have found is, since we don't do a whole lot of covered stents, we usually just deploy a Supera, usually a 4.5 Supera, depending upon where the crossover site is. That kind of decides the length of the Supera. And the beauty of this is you can actually use it to stack it at those sites where you see a lot of AV fistulization. So you can get near perfect stacking and closure of those big AV fistulas. So we've done that multiple times now. And what happens is the angiogram that used to look like this, really sad and pathetic, begins to start looking like this in less than 2 hours. So you get a decent result this way. And then this patient is the one with the heel ulcer, I think. So you see the angiogram that used to look that way now looks much better. And I'm going to show you one more of the other patient. So you can see this is a second case where there's hardly any posterior tibial flow. And at the end of the case, there not only is there posterior tibial flow, but there's a little bit of flow beyond the pedal venous arch. So these are the kind of results you can obtain. But the proof is in the pudding. So when my foot and ankle surgeon took this guy to the OR, he said, "My God, man, this guy bled all over the floor." So this is always a good thing to hear. And this is the second case. You can see there's brisk bleeding from that horrendous looking foot. So both these patients have healed their wounds. How do we follow these patients up? We usually follow them every 2 weeks for the first couple of months, actually, and then perform a arterial/venous duplex and measure peak systolic velocities at a couple of sites shown in this picture. Typically, the most critical thing I've found is at the bottom of the stent, and then a volume flow that usually needs to be more than 200 to 250 ml per minute. So that's usually how we follow up our patients. And I think that's kind of all I have to say. So in summary, what I would say is, get your skills up, make sure you have done a fair number of tibial interventions, partner with a good foot and ankle surgeon who knows how to take care of these wounds, learn to puncture veins and get venous access, and then be able to deal with these valves. Use IVIS whenever you have any questions. So thank you.
Absolutely. No, thank you so much, Sid. If you can stop sharing so we can see the team and we have a little bit of a discussion here. There's a lot to digest. Thank you so much for that nice presentation.
Thank you.
One of the things that, one of the questions in the chat was about the pressure that we apply to the cuff. Let me answer a couple of these quickly. So we usually have 100 to 120 millimeters of mercury in the cuff when we're taking the pictures. If using a cuff, some people just use a couple of tourniquets. Sid was showing he was using tourniquets. I like to use the cuff. I think you get much better pictures. And I didn't talk about it when I was doing the presentation because I was going so fast. But the way you take the picture of the foot is very important. So you want to have the cuff up at 100, 120. And then you want to inject 20 cc's of saline first to get the veins plumped up. Then you want to take a 20 cc syringe, 80% saline, 20% dye. So you don't need much dye. You basically need 2-3 cc's of dye. And then you want to do a slow but then rapid injection, and then hopefully fill up the arch and all the tributaries and collaterals so you can see a good picture of the foot. So that's the way we do the venogram of the foot once we have access and we have the sheet in. And then there's a question here for distal DVA. You try to get into the dorsal metatarsal vein of the arch and dilate the valves there, or is it enough to limit to the arch? I know that I've had a couple of colleagues that have suggested doing that in our group for the lymph flow as part of the PROMISE 2 and some of the cases we've done. I honestly myself have never had to do this. I've never done it. I personally don't think it's necessary, but maybe it does enhance the blood flow to the distal toes and distal foot. I think if you, more importantly, which we didn't get into, is that, sometimes you have to, a lot of times maybe, you have to come back and do some coiling, and you need to direct the flow to the distal foot. I think that's probably more important. So you need to follow these patients. You need to keep an eye, and maybe we can have another session, next time or soon, where we talk about the follow-up of these patients from a duplex ultrasound standpoint, because you really need to understand the duplex ultrasound, some of the things that Sid was talking about the volume flow and what kind of numbers you want. What is the proximal steal? What's the distal steal? What's the high flow? How do you deal with it? There are some of those issues that you need to take into consideration. So I think the more important question is that, have you done all you can to get the flow to go distal by coiling the proximal tributaries and branches and small saphenous vein and those things that are stealing blood at the level of the ankle from getting to the foot? The next question was, I'm sorry.
I want to ask you a question. Can you describe any anatomic conditions of below the knee arteries where you would not do a DVA? So you showed your case where there was a very good AT and there was a beautiful PT and that was occluded distally.
Yes.
So you couldn't go very distal. So if there is a single or marginal below the knee runoff, below the knee vessels, would that patient be a decent candidate in the presence of a PT?
Right. So far, I think that is a very good question and very provocative question, Subhash. So far we have been very, very strict. I think some people have cheated, if you will, out there, and they have done easier cases where there may have been a DP but not a PT, or there was a PT not a AT. I'm talking about colleagues out there. I've seen a lot of cases. But we have been very strict because of we were part of the trial. We stayed kosher to the fact that if the patient had a DP or a PT, we didn't do it. They had to have no flow they had to have no revascularizable, bypassable DP or PT and failed endovascular. At least in my practice, that's the way it's been so far. Now,
lead up question.
What you're asking is something different, I think. What you're saying is that if you have a patient that has a AT, but it's missing a PT, and the wound is not healing. Is that correct? You're saying the wound is not healing. You have a AT, the PT is not, the PT is occluded. You have a heel wound, like Sid said. Wound is not healing 3 months, 4 months, 2 months, 6 months. Can you offer DVA? Honestly, in my opinion, I don't see why not. Because I don't think you're going to take any options away. Because we work on the artery that's occluded. We don't work on the artery that's open. So as long as you're careful, you're doing this carefully, like everything else, you know, no more careful than anything else.
I want you to give short responses because we have very important questions, because I don't do DVA. We are starting to do DVA. So the questions I have is probably representative of most of the people who want to hear this.
Yes.
So if in this case you just described, if the PT is occluded very proximally, and you need a reasonable amount of stub of the PT, could you do something about it? If there is no PT, that is, you can partially recanalize it arterially. What are the options there?
100%. Okay, quickly to respond to that, you know, what you can do is that you can do subintimal, get some purchase into the PT, and then you can finish up the DVA with the DES in the proximal portion with overlap to the cover stent. So, yes.
Next question. Can you visualize venous valves with intravascular ultrasound? And can you, instead of using valvotomes like Sid demonstrated, use laser to effectively go to the very, very distal crux of the vein?
I think Sid and I have a little bit of a difference here. We mentioned it also at CVI. In my humble opinion, I love Sid, and with all due respect, I just don't think a 1.5 or a 1.7, and my experience with these valves is that it's going to destroy these valves, because, you know, even if he pokes a hole in it, he's not going to damage these valves. Even when we do the valvulotome, to be honest, and we are pretty aggressive, like I said, we rotate, we go up and down, we are banging these valves hard. We still see residual waste with the balloon. Now, if you do cutting balloon and aggressive ballooning, you can get them. So you may not even need laser, to be honest with you. But I just don't think the laser 1.5 or 1.7 can really take care of, because we know from experience from arterial work that this laser doesn't have a lot of surface area. Like the surface area that we get, you know, is very much what you're getting in the catheter.
Got it. Last question. Is DVA in your trial and the approval is only for the posterior tibial vein?
No, that's a great question. No, we had majority of these were done in the posterior tibial, majority, but we had some in the AT, and I think we had one in peroneal. And I've done myself, I've not done peroneal, I don't think, but I've done definitely AT, maybe 2 of them. Most of them have been PT. It's just easier. It makes sense. It gets the flow all the way to the arch. And so in the trial, I think 70%, if I recall correctly, were PT, 70%. And then the rest were AT, and then a few of them we had that were peroneal. So the answer is no, it can be AT or the peroneal.
Got it. I think this was an awesome session. So we have actually gone way over our time. Any concluding remarks from all our 3 great speakers, and then we will probably close and take the rest of the questions probably through our personal CVI emails and chat functions. And this is also going to be posted on social media. So please feel free to join the discussion and also post your questions there.
You know, one of the questions, Subhash, I think, you know, let me just make one comment here, because I think it's an important comment. I mean, until now, and I think I'm just being provocative, and I know you like to always be provocative. So this time I'm going to take the helm on this one. And one of the challenges in our field is that until now, we honestly didn't have anything, meaning that we started the Promise 1 with 6 sites in the United States. Promise 2 were like 20 sites. And Promise 3 is like 30 sites, 25 sites. But so people were forced, including myself, to do off the shelf. There were patients that were did not qualify for the study. And we wanted to take care of these patients. And we as physicians, you know, we always want to push the envelope to try to save somebody's limb or life. And to me, they are the same, honestly. There are a lot of patients that rather die than lose their leg. So now that we have the FDA approval, I think it's going to be hard, even legally, to justify not using this technology. Like you have to make a good reason why you would not use this technology that has FDA approval, has done the proper studies, have the devices that have been approved by the FDA, because there's the FDA specific indication for this technology, which is exactly what we're talking about. Route 4, 5.
So the answer for that is very simple, Mehdi. There are still many operators that don't believe that this technology works, number one.
Yes.
Number two, there aren't enough people who are skilled enough to do this in a safe way, in a multidisciplinary way. And number three, the exorbitant cost of the device for it's not available even in hospitals. It only can be afforded by multi-billion-dollar hospitals, not by community hospitals easily. And just to respond to that, the proof is in the pudding again, right? So Zola has learned this technique from me. A couple of other physicians have learned this technique from me. You should try this once. And I'm not kidding. The laser does work. And why do I know it does? Because you can inflate a 1-to-1 balloon in the veins, and you don't even have to go to nominal pressures, and you don't see that napkin ring sort of lesion that you typically see when you have a valve that is still functionally persisting. Yes. And you can see, like, none of the Superas I deployed have any constriction. They're wide open. Yes. I mean, this has been a game changer for how smoothly the process goes. I mean, we have a DVA day when we do 3 DVAs and we are done by 3 o'clock.
Yes. Well, we didn't do bad. We did an hour and a half and we taped it. So that wasn't that bad. Don't give us some credit.
No, I know. You know what I mean.
But what I'm saying is that I think that, I think the company has a lot of work to do. I agree with you.
Yes.
I think the cost is an issue. I think the reimbursement, I think they're going to work on the reimbursement. I think once the reimbursement is settled and the cost issues are taken care of, you're absolutely correct. There's a lot of education that needs to happen. As you can see, there is a lot of complexity around this, not only with the procedure, but also all the things that Brian was talking about and the education that needs to happen with that. These patients also come from a lower socioeconomic class. They don't have a lot of resources. Their pain can be sometimes challenging to manage as an outpatient, to be honest with you. So there is a lot. I agree with everything you said, by the way. I think that, and the laser, I will try it. I just want to see it myself. But you're right. There is, but my hope is that, and I also feel like if a company is willing to do the trial, willing to do the research, obviously we need to address the cost. And we need to address the reimbursement. This is a fact of life. We all know that. But I think that if those things are hopefully addressed, that means that we have reasonable reimbursement that matches the cost, and the cost is reasonable. I think that we should support the research and not because I was in the study or because I published it. Otherwise, there's no reason to do research. Because if people are going to do their own thing, then what's the point of even doing the research? And I think as a scientist, as all of us are, we have to advocate for this kind of to support the research and the scientific work that's being done. But, I think that all the work that you've done has helped the field. I mean, all the work that you and others have done has helped the field, and all of us together, we're trying to create safe limbs and help the patients not lose their leg. I think that's been the goal.
Yeah, I 100% agree. Subhash, just one quick thing. I didn't want the people attending the webinar to think that unless they have the lymph flow device in their hands, that they can't help their patients. I mean, for patients who have 100% chance of BKA, anything other than the lymph flow device, if you unfortunately don't have it, there is some hope for these patients, is all I'm saying. That's all.
100%. I support exactly what you're saying. And we need to, spread this technology and hopefully get it in the hands of people that are very committed in saving limbs. That's for sure, 100%. Brian, let's give Brian a chance. Anything you want to say, Brian? You have done a lot of these, and you've been very involved.
No, I mean, look, I think it's just important that, we do a better job at really kind of educating our counterparts and really in podiatry and our orthopedic colleagues. There's a lot to get done to get people trained up to be able to understand the technique and to be able to have successful outcomes. So the hope is we just kind of keep pushing the message, educating and teaching those who want to do the work and have the passion to want to save the limbs. And we know it works. And we're really creating an experience for patients that didn't exist a few years ago. So, let me ask one more question, Subhash. I know you want to go. I think Subhash has a date.
but usually he wants to stay, but tonight he wants to go. I don't know what's going on. But let me ask one more question because we have good conversation. Brian, I know you just opened with our friend Dr. Montero Baker and ASC, and if I'm not mistaken, and he's
an OBL.
an OBL.
Yeah.
Okay, an OBL, and obviously both of you are huge lymph flow. How are you able to? Are you doing lymph flow in the OBL? And what is your take on it? On the whole lymph flow in the OBL setting, and with your work with Dr. Montero Baker.
Yeah, currently we're not doing in the OBL, and I think it all goes about cost. I know that Miguel probably does more off the shelf at this point. We do have hospital affiliates that will carry the lymph flow devices, and those cases can get done there, but currently not happening in the OBL. And I think it's all just a dollars and cents conversation there.
Right. Yeah, I think that's the important point for the company to, I hope there's somebody listening, and that we need to address this aspect of medicine. I mean, this is the truth, the honest, that we have to be able to buy these devices and be able to offer them to our patients. Subhash, you get the last word, man. Go ahead.
No last word. I'm already late for my date, Mehdi, thanks to you, so I missed it. But anyway, I will get back. But it has been a wonderful conversation. I think this is one of the most enterprising technologies that I've seen being in this field for such a long time. And I do truly believe that I read the study very carefully, and also all the data points. I think it is going to set the stage for how CLI studies are to be done in the future. There are still a lot of unanswered questions. The ESRD patient population, the need for repeat interventions. So one last question, Mehdi, what kinds of repeat interventions that you had to do in these patients? In those where you were technically successful? Be brief, because
very brief. I think there's a misnomer there, because if you read the paper, there was a lot of reinterventions, but we didn't get into the details of this in the paper.
Yes.
And the truth of the matter is that I would say 70% are coiling, because these patients have distal steal and proximal steal, and the distal steal needs to be addressed by coiling. Plus, we were learning, like in the beginning, we didn't go as distal with a stent. So we missed some of those branches in the calcaneal area.
No, don't get me wrong. I'm actually absolutely thrilled that the limb salvage rate was enormous. I mean, I've never seen anything like this in my lifetime. And even if these patients have to come back for a few interventions and they're able to save their leg, this is a big deal. I think the emphasis of the point was that whether this is coiling or you are seeing some residual stenosis, in the scan, that was the emphasis of the question.
Right. No, I got your point, and that's what I was trying to emphasize, is that, as a matter of fact, most of the intervention, I would say 70%, are related either to proximal disease, like native arterial disease, or they are related to coiling and dealing with distal steal. Not this per se, the stent graft itself. I mean, it's a covered stent, so there's not a lot of things that can go wrong with it. It could thrombose and close, don't get me wrong, but that was not the majority of the issues.
That was not. That was my question. It was not a conduit failure, and that is exactly what it is. But anyway, gentlemen, congratulations for this wonderful webcast. We have never had these many attendees and such a large number of registrants, and a lot of interest generated in this field. I'm sure this is only the start. And folks like me are excited to get into it and learn and hopefully do it correctly with the help of a multidisciplinary team that Brian LaPaul so elegantly has articulated. I learned a lot of good things. Brian, you speak wonderfully, and I think having you as part of our of CVI and also our presentations along with Sid has been a great pleasure. So looking forward to see you all back in Denver.
Yeah.
Thank you so much.
Thank you.
Bye-bye.
Thank you very much.
Bye.
Good night.